There's a huge overlap between vascular pathologies and Alzheimer's pathologies. Postmortem studies show this, and we haven't been appreciating that. So that affects the way that we diagnose people, treat people, and it particularly affects how we populate clinical trials. So in order to really appreciate how that overlap works, like if the two pathologies are basically separate and they have additive effects on cognition, that's what it looks like. Or if they promote each other, maybe vascular pathologies promote beta amyloid deposition or tau, or vice versa. We really need to model that in animals. So what we've been doing in the lab is we're taking different models of vascular pathology. So what I presented here today was a model of hyperhomocystinemia that causes microbleeds, and a model of bilateral common carotid artery stenosis that causes hypoperfusion. And then we mix those, or we recreate those pathologies in animals that are transgenic for beta amyloid or tau, which are two predominant Alzheimer's pathologies. And then basically once we put them together, we're looking to see if they promote each other, if they change the cognitive outcomes. Honestly, I think that the biggest point of impact that it could have is letting us better understand how to include and exclude people from clinical trials. So for example, if you're populating a study and you want to do an antibody against beta amyloid, which is one of the things that we're looking at for Alzheimer's disease, and a significant number of people in that population have blood-brain barrier leakage or some kind of vascular pathology, and you put this antibody in, that could explain why some people react poorly or have encephalopathy afterwards. So if we, maybe not so much, it doesn't help us identify them, but it just helps us to know that we're supposed to identify them. So if they're excluded early, if we know how that reaction might happen, then we don't include them, and we can find a drug that might have efficacy in a subpopulation. And it also helps us to understand how to treat both pathologies in the population that has more than one. And if we're treating both, especially if they're additive on cognitive impairment, if we're treating both, we're much more likely to see a real effect. I mean, the population is just exploding, it's growing exponentially. And also, there's some other statistics that go into it, like we're getting really good at preventing people from dying from stroke. We're getting good at managing other cardiovascular diseases. And as those people live, they go on to get dementia or Alzheimer's. So the pool of people getting Alzheimer's is growing, or dementia in general is growing. Prevention is a huge thing, and it's actually, in dementia, it's really the only thing that we are competent at doing. So there's some things that we know, like calorie restriction really helps keep people stay healthy, and it really helps them avoid dementia in later life. You know, it's things like antioxidants, kind of dietary components, a little bit of exercise, not eating as much meat, and pretty much anything that helps the heart helps the brain. And I think that's becoming clearer and clearer, especially when you're looking at mixed dementia pools like this. So early intervention, if you make a lifestyle change earlier in your life, I think we have data that supports this, but I don't know if we can say it for sure, but why not? It's not going to hurt anything, and I think it's probably the single best thing that you can do to prevent Alzheimer's. But for later intervention stages, we're still not there yet. So if we can manage, well, we can't really manage the Alzheimer's symptoms. We don't have pharmacotherapies to do that. We're working on those. But if we can at least manage the vascular pathologies, we can help prevent decline, especially if they promote each other. So if vascular pathology promotes Alzheimer's beta amyloid deposition, and we can manage that, somebody should decline more slowly. And so it's not complete prevention, but it's partial prevention, and we can keep them in a state maybe of mild cognitive impairment, which has got to be better than full-blown dementia.